from there. And Dr. Maury, did you want to say anything to get us going?
No, I mean, it's just really, I just wanted to, to hopefully have a decent showing, because I think this is really important because we can, increase our reimbursement, and also we're going to be working on these quality and or these alternative payment models, and I know these are coming down the pike with Medicare anyway, and Maryland is fortunately able to get ahead of the game because of our Medicare waiver. So I just wanted to put that out there, and I think it will be beneficial for rheumatology and other specialty practices.
So for those of you who don't know this, Dr. Maury is actually on the MedChi Board of Trustees and is one of my bosses. So she has been super helpful over the last year or so. She's been to Annapolis to testify against prior authorization, and she's helping me with some technology stuff at CRISP, and she's also agreed to be the lead care partner for the MedChi Rheumatology EQIP entity, and we can talk about that a little later on. But I just want to thank her for all the volunteer time she's putting in for MedChi and for your Rheumatology Society as well. So it makes a big difference. For those of you who don't know me, I'm Gene Ransom. I'm the CEO of MedChi. And today we're going to talk about the Episode Quality Improvement Program. And specifically, we're going to talk about it for rheumatologists, the bundles that are available for rheumatologists. And to do that, I'm going to turn it over to Jessica from CRISP. Jessica is the main manager of the Episode Quality Improvement Program and is excellent and been doing an incredible amount of work on this over the last few years with us and is terrific. So Jessica, take it away.
Thanks, Gene. Thanks, Dr. Maury. Okay, so let's talk about this Episode Quality Improvement Program, or EAP. Maybe you've heard it thrown around, maybe you haven't. So we'll kind of start with an overview and then get into some specifics as it pertains to the rheumatology specialty. So just as FYI, I am Jessica. I'm with CRISP. I think my colleague Will Daniel from the HSCRC will be joining us in just a second. About that. We want to point out that if there are any questions following this meeting, you feel free to reach out to either one of us directly, but we also have this equip@crisphealth.org inbox, which is a great way to get to the right person, whether that be a policy related question or some help with the CRISP system. We'll get you to the right place. If you have any questions, that's always a good place to start. So EQIP. EQIP is a voluntary program. Previously, under Maryland's total cost of care, obviously we have the priority of reducing costs and improving quality. But due to our model, historically, Maryland physicians have, especially our specialty physicians, in large part have been ineligible to participate in some of the national Medicare value-based programs. So a couple years back, probably 3 or 4 years back now, the state went about with the goal of creating their own program to be centered around specialists. So EQIP is the very first specialist-focused program that's designed to achieve both that cost and quality in and out of the hospital. Importantly, it is voluntary, so there's no mandate to participate, but we do want to point out that there's a lot of perks. So we do hope that that those people do participate. And essentially, with most value-based programs, it's tying an approach that looks at healthcare payments and quality and cost. So we hopefully are incentivizing providers to reduce cost, improve quality, and it'll be a win-win for both the provider and the state. So EQIP it utilizes something that's called a Prometheus episode grouper, which is the methodology of how a clinical episode is defined. We'll go into a little bit more detail about that, but you'll hear me kind of reference Prometheus. And essentially that is, again, the clinical understanding of the episode. At a high level, we want to emphasize, 3 big takeaways is that this is a physician-focused program. We really wanted it to be centered around physicians, not the hospitals or their employer. Physicians can own and monitor the performance in the program. And secondly, probably the biggest thing here is EQIP was designed to have upside financial risk only. There is some savings accountability. Essentially, there are some guardrails for continued participation, but there is absolutely no financial risk when joining this program. And finally, EQIP does qualify as an advanced alternative payment model. So therefore, it gives participants the opportunity become eligible for a bonus if they meet both quality and savings goals, which is wonderful. Currently this year, that savings is about 3.5%. We're optimistic that that will continue for next year, but there is, again, this great opportunity by just participating in the program, you get this bump from a Medicare payment standpoint. Timeline. So EQIP does run on a calendar year. So we're talking about in the enrollment cycle, which is right now, it's ongoing from July and September, but it is enrollment for next calendar year or calendar year 2023, which is actually the third performance year for this program. Everything really is done on that annual cycle. So this enrollment period, which ends Friday, September 1st, the next opportunity to enroll for the calendar year 2025 won't be till July of next year. So again, now's the time, now's the opportunity. Additionally, that follows the payment cycle as well. So while the calendar year for performance year 3 is 2024, payment is about 9 months after the close of that calendar year. So if you participate and you earn shared savings, you're looking at that payment or that check coming to your group or you individually in the September 2025 timeframe. So here in performance year 3, we actually have 50 episodes that are available. I do want to apologize. We group these just in a way to look at the episodes. By no means do you have to be that type of specialist in order to participate in the episode. In fact, I highlighted the ones that we're going to talk about here that align greatly to the rheumatology specialty, which is low back pain and osteoarthritis. But you can see there's across the gamut a lot of different types of specialties and provider types that are eligible to participate if they trigger these types of episodes. I included a link here and you'll see it again later. Full detail on all these episodes. We have a playbook that is available for you guys to look at. Again, all the different types of codes and stuff that goes in.
I just wanted to point out here that just because we have these 2 episodes, it doesn't mean that we can't add more as a group to try to make it more our own, because I know most of us do things like treat rheumatoid arthritis, and that's a very pertinent to us and would probably be a better fit for what we need for rheumatology.
Yeah, I think that's a wonderful point, and actually something that's great because this is a very flexible type of program at the state level. So we have some episodes, the emergency department episodes are a great example, which did not exist in the sort of the Prometheus model or essentially off the shelf that we could use. And led by a clinician, we were able to develop these episodes specifically for that specialty. So I think it's a great opportunity, and we definitely would be very happy to partner with clinicians moving forward to look at adding more specific episodes that are more aligned, I would say, with your guys' specialty. So look forward to that a lot. Okay, so you'll hear me use a couple acronyms as we continue these next couple of slides. All policies really like acronyms. The first is you'll hear a CRP entity. Essentially, this is a single Maryland hospital, UMC in this case, in which the physicians sign a standard care partner arrangement with. This is an element we'll chat about a little bit more, but basically, the CRP entity is what the state is using in a strictly administrative function in order to pay incentive payments to the participants. Moving to this next column is the EQIP entity, and this is really the participation function. So it can be an individual physician. You can choose to enter in by yourself, or you can choose to enter in, with your colleagues in your practice, so a collection of physicians. It's any grouping that you would like to participate and be evaluated in an aggregate. I think that's the important point here, is that the entity is at level in which we assess the performance. So if you're going by yourself, of course, your performance is based off of you alone. However, if you are participating in an EQIP entity with multiple physicians, it is the aggregate performance of all of that physicians in that group that determines if you receive a shared savings. The next one is what we call a care partner. It's a little bit of a CMS terminology, but essentially it's the specialty physician. These are the clinicians that are actually performing the clinical care. As mentioned, each individual care partner physician will need to sign that care partner arrangement in order to officially be in the program. And just as a note, all of the providers or practitioners in this group will continue to receive their normal fee-for-service payment. For Medicare, this is just an opportunity for a potential incentive payment on top of your typical billing process. And finally, we have HSCRC and CRISPs. HSCRC is the primary policy driver who determines how episodes are calculated and the methodology for this. Both CRISP and HSCRC are responsible for maintaining the reporting requirements to CMS. So there is no additional reporting burden placed on our participants. And then finally, we have this bottom role, which is called an administrative proxy. And essentially, this is a support role for a physician or physician group that they can delegate management of their program. This could be your practice manager or administrator, or it could even be an external consultant. It's whomever that group of physicians would like to engage in order to help them manage participation and do some of the initial enrollment processes in the program. And by all means, that is not a requirement. That, of course, can be managed by a physician by themselves if that's how they choose. So let's talk more about that CRP entity, since sometimes it can be a little bit daunting. We're saying, what's going on with like what's going on with this? So again, this is a single Maryland hospital that's taking on this CRP entity role. And it's really this partnership is the way that we've been able to establish EQIP as an advanced alternate payment model. While UMC was selected, any qualifying physician in Maryland is eligible to participate, regardless of your prior or current relationship or even privileges with UMC. A physician could never be in touched foot anywhere in the system. And again, you're still allowed to participate. There's no requirement of a relationship there. And essentially, this is because that CRP entity has two main roles. First, they receive a list of all of the physicians who are choosing to participate and generate that standard care partner arrangement for the care partner to sign. And secondly, they distribute the checks. So the HSCRC at the end of the year does all of these calculations and essentially tells UMC to pay each entity a specific amount, and UMC will cut the check. So again, want to emphasize that UMC does not have access to any of the protected health information. There's absolutely no data sharing arrangement that needs to happen between the individual physicians or the practices and UMC. They really are quarantined to that administrative functions that we just discussed. And again, any policy decisions would come through the HSCRC with the support of CRISP as well. So now we get to the how do I participate? These are sort of the minimum requirements in order to get into the program. So first is you qualify as a care partner with CMS. To do that, most people do. We have a very low rate of those people that don't qualify. You're licensed and enrolled in the PICO system. You use a certified electronic health record and are participating in Maryland's Health Information Exchange. To actually enroll in EQIP, essentially you're saying, how am I going to participate? Am I going at this by myself, or am I going at this with my partners or other groups of physicians? So establishing that EQIP entity and selecting what episodes you're going to participate in. Additionally, that entity determines a single payment remission recipient. So that's a single source that we send the check. And you sign the arrangement that we just talked about. Finally, we determine your eligibility based off of certain volume thresholds. So for a single episode, there's a minimum threshold of 11 episodes in the baseline period. And across all episodes, there's a threshold of 50. So for example, if you're participating in both osteoarthritis and low back pain, you could have 20 of one and 30 of the other to make up that 50. However, if the participation is in a single episode, let's say osteoarthritis, you would need 50 of that one episode in order to meet that criteria. CRISP is also happy to support and run any numbers or NPIs that if you have some questions about your eligibility. I do see a hand, so why don't I stop there?
So sorry to interrupt, Jessica. I have a very quick question about this whole episode thing. So does this mean that when you say episode, does it mean that many diagnoses or that many patients with the OA diagnoses, or one patient who we see multiple times?
So both of the episodes that we're going to talk about today are chronic episodes. So it would be a single beneficiary in that time frame, knowing that they're likely going to see you multiple times over the year. Some other episodes are a little bit more discrete or episodic. Ironically, like surgical ones, it's an actual surgery, and then potentially that beneficiary could have another surgery later in the year, and that beneficiary would count for two. For these particular ones, again, they're triggered at essentially the first time you have an E&M visit with them that has one of these diagnoses, and they maintain, they're part of the episode for the rest of the year. So I'll get a little bit more into detail when I talk about episode, but for this case, for the most part, it's a singular patient that we're sort of counting as an episode. Hopefully that answered your question.
Thank you, yes.
Okay, so a little bit of Prometheus, and it's great because we're kind of diving right into the, like, what am I saying by episode? What do I mean by this? So background on Prometheus, it's an algorithm that's been in development since about 2006. It currently is owned by Change Healthcare or Optum. They actually own the algorithm, and they have the proprietary knowledge or intelligence for this algorithm. One of the primary reasons we selected this is it does promote coordination and collaboration across the continuum. And a big positive is it already had 97 episodes developed in Prometheus, so it allowed the state to really ramp up quite rapidly. For example, in year one, we had 15 episodes, and now we're up to 50. So that's been a positive about using Prometheus.
And just since the purchase has occurred, we're looking at alternatives to move away from something that's owned by Optum, obviously, because Optum, in my personal opinion, is evil.
Again, Jean's opinion on that. But so what is Prometheus at a high level? It's a little bit different than some other models where it's not true total cost of care. It really uses this logic that they call all relevant costs. So essentially we're looking, of course, we start with total cost of care, and their algorithm weeds out costs that are not assigned to the episode, that may not be underneath the purview of that specialty or that provider, and really get to hone in on the relevant costs of that episode. From there, there's again additional logic that kind of helps highlight opportunities, whether that be overuse services or setting selection that could help drive down costs, or even potentially things in the claims that would show potentially avoidable complications as an opportunity of how you would look at cost reduction. So the episode of care it's sort of a full spectrum. So it starts with an initial triggering event. Again, I'll talk what those specifically are for osteoarthritis and low back pain, but it's typically either a combination of a CPT code and a ICD-10 diagnosis. And once that episode starts, there's typically a pre-trigger window. So we'll look a certain amount of time before that triggering event, and then a post-trigger period. All of those are configurable based off of the episode. So it's not one amount across the board. Pre-trigger periods can be as low as 0. They don't look at anything, but most typically we see about 30 days before the episode that we're looking at the relevant costs to also include in the episode. And post-trigger period, again, we have shorter ones that are 14 days, and then long ones that last the length of the calendar year for that performance year. So let's get into what I'm talking about and what that actually means for the specific episodes that likely are most relevant to you guys. Just as a note, when we send this out, there's a link to the full playbook that has even more information that's here. I'm just trying to highlight the top one. So both low back pain and osteoarthritis fall into what's called a chronic condition episode. And essentially what that means is the episode is triggered on an inpatient service or an outpatient professional E&M code that has a specific low back pain diagnosis. In the instances that it's triggered in the outpatient side on just a professional trigger, it does require a confirming service within the first 30 days. And this is to basically ensure that it is truly a patient that sort of belongs in this episode. But once that triggering event does occur, there's a look back period of 30 days after that initial event. And the episode length really lasts till the end of the calendar year, so December 31st of 2024. And again, all of that time frame, there's relevant cost that's considered in there, and that's what's incorporated into the target price associated for the episode. Apologies. You guys know these way better than I, so this is a little bit more informational, but you can see the ICD-10s that are going to be linked to that initial inpatient trigger or E&M code. I think there's 2 pages here. Again, happy to send this out so you guys can see this. And then in the playbook, we also list all of the things that are categorized in that relevant cost bucket. Osteoarthritis is pretty much the same way. So it's a chronic episode. It can be triggered on an inpatient stay or an outpatient service with a another confirming service within 30 days. looks 30 days beforehand and goes through the end of the calendar year. And again, we include the ICD-10 codes here for you guys as well. A little bit about attribution, because chronic episodes, we talked, it can last a really long time. They're seeing multiple visits. It's not a singular event. So how does the attribution work as far as assigning the cost to a single physician? So as we just talked about, the first step is there's a triggering event that determines that the patients are eligible for this episode. I think we use a different example here, but as you can see, inpatient or outpatient. And essentially, we follow that patient throughout the whole entire calendar year, and the attribution is given to the physician who provides the plurality of all of the relevant E&M services to that beneficiary. So that may not be that very first physician that sees the patient and opens the episode. It could be, and hopefully likely so, because they're continuing to do follow-up. But we want to ensure that essentially the physician that sees this patient the most, that has the most touches with this patient during the time, is the one that's attributed or sort of owns that episode for that patient. And again, it's all the costs sort of, again, that episode's assigned to one physician sort of at the end there. So there may be times that it could change, like in the first quarter of a year, one provider could sort of be the main attributing physician because there's only a couple E&M codes, but as the year goes on, you'll really start to see, okay, which patients do I actually own based off of, again, the frequency or plurality of the E&M services. So hopefully that made sense. I'm going to move out of the Prometheus world and get into the policy and methodology side of this. Let's see. Hey, Jean, do you mind letting Will in? He's in the waiting room, he said. Okay, so the EQIP policy and methodology side, target price. So how do we say if you guys have reduced cost in the year? So we use calendar year 2019 as the baseline. It's been the baseline for the first 3 years. And basically to do this, we assign a unique target price to each EQIP entity. So again, you have multiple providers, we'll let you know sort of where their numbers fall, but your entity in its whole gets a singular target price. So to do this, the HSCC will look at the weighted average cost per episode across all of the providers within an entity and aggregate that to create that unique target price for the entity. Essentially, then we trend that number forward, so it will be in calendar year 2024 costs, and it essentially allows the entities to compare their real-time target price to their real-time performance. I just want to note one thing is that the final target price is not done until the end of the calendar year, and that is because we get multiple inflation updates throughout the year. So as the state gets them, we will of course update those target price to reflect the most recent inflation factor. That's about it. Just again, an important note is that target price is set independent of the setting of care. So that means across all the different settings that a practice may provide, inpatient, obviously outpatient services, if there are any procedures that could be done, obviously in a regulated setting or an ASC, it's still a singular target price. You have the availability to look at the discrepancies between or the differences between the costs in those settings and see if there's opportunity. But again, it's a singular target price, regardless of where services were rendered. And I see you have a hand up.
No, I just wanted to kind of point out that, physician reimbursements or compensation is not currently tied to inflation like the hospitals are, and this appears like it will be tied to inflation. Like they'll, improve the payments, or the cost of care, they'll adjust it for inflation. That's correct? That's what you're saying?
Yeah, so your target price, essentially, we're not saying you got to beat the numbers that were in 2019 without it, like accounting for the fact that there has been some inflation since that time frame.
Yeah.
So we make the numbers in essentially today's dollars so that we can ensure that, if there is improvement, it's actually being shown in the numbers as opposed to being disadvantaged with the not incorporating inflation.
Okay. Yeah, and I also just wanted to bring up that I mentioned it earlier that we'll be able to kind of create our own, things for rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, which I think are, like you said, more aligned with what we do, and I think are actually going to be a lot more beneficial for us in the long run. And so I'm really looking forward to being able to put together an alternative payment model based on what we actually do in rheumatology, because I know we all see back pain and osteoarthritis, but it's really not our bread and butter.
And I think this is again, the line may not be perfect, but I think understanding how sort of the episodes are created might help with that development as well. Wonderful.
Yeah, this is basically a way for us to get our foot in the door.
Yeah. Good way to describe it.
I have a quick question about the low back pain. So, for instance, patients with inflammatory spondyloarthropathies being treated with biologic agents, obviously they'll be costing a whole lot more than a basic person with low back pain. So, how would that factor into the cost of care when, in fact, those are two very different subsets of patients with low back pain?
Yeah, so there's a couple of different ways. First, and we'll kind of explain from the target price, you're essentially trying to beat yourself. So the idea there is that sort of the aggregate or the mix of patients, those that had biologics in 2019, there's probably, hopefully mirrors somewhat similar in 2024. So your target price is actually already inclusive of some of that differences. So you're trying to beat yourself as opposed to like beating a state average, someone that may not have the same type of practice that you are seeing. So that's sort of one. And just as a note, and getting a little about my expertise, I might have to tag in Will here, but Part D costs are not included in here. Again, that's just a little bit because of the way that the insurances in some patients, may not have the full coverage in the Part D world. So some of those costs may not actually be included. Will, do you want to add anything to that?
That covered it.
I have a question. So if we go back to the, because we might see a patient that we start out saying, oh, they have low back pain, but then their ICD-10 code changes to one of these inflammatory arthropathies, and they, I don't think that those ICD-10 codes are actually in the list that we're looking. I wasn't. Well, M46 might. Well, no, that's yeah. So I guess I'd have to look at it a little more closely. Oh wait. Oh, I did see the inflammatory. Sorry, if you go back. Okay, so it is in there. Okay.
As I apologize, I think we're getting out of my level of expertise when it comes to the codes. But I think one of the things to emphasize is that the methodology it's quite literal. So it is this diagnosis code that's attached, to an inpatient or an E&M visit that triggers an episode. So hopefully, obviously with your guys' clinical expertise, and we have additional data available in the full playbook, it would help explain some of those sort of patient scenarios. But sounds like hopefully that answered your own question. Okay, great. Apologies, let me catch back up. Okay, so now let's talk about how we actually calculate if people get paid. So essentially, this is a 5-step process. So at the very end of the performance year, the end of calendar year 2024, we assess the results seen across all the episodes in which that entity is participating in. So again, the aggregate across all the different providers and all the different episodes, and we determine if it's less than the target price that was determined in the beginning of the year, and we check if there's a minimum of a 3% savings that's met. And we do require that minimum 3% savings to ensure that the savings is considered statistically significant. But once you're above that 3% savings, you fall into a tiered shared savings where you actually get a check. So once that check is, or once that 3% is met, we look at the baseline data, and EQIP entities are compared to statewide experience, essentially ranked on efficiency. And it gives us the relative shared savings that will be paid out. So higher cost practices or physicians are ranked lower, and thus a lower percentile is shared with the practice, and our efficient or low cost practitioners are ranked higher and a higher shared savings. So when we look at this, what does it exactly mean? The lowest tercile has a 50-50 split with the state. Those that are in the middle tercile, the state will get, or the entities will get a slightly larger payout of 65%, with the state keeping 45%. And then finally, if you are in that top tercile, the practitioners keep 80% of the shared savings. The sort of reasoning and thinking behind that is that if you're already pretty efficient in baseline, it's going to be more difficult to create additional savings. So therefore, if you create savings, you should keep a larger portion of it. Whereas those that are high cost or less efficient providers during baseline may have more opportunity or low-hanging fruit to get them to achieve those savings, but we want to they would get a larger slice of the pot for that example. Do you see another hand?
So a question, Jessica. So for a specialty like rheumatology, where most of our relationships are really lifelong chronic illnesses, which vary, and the costs are going to really vary about the disease severity and how, the drugs that the patients are going to be on, so really this incentive payment methodology, the incentive is really for costs. It doesn't really include any quality measures or anything else. It's primarily cost savings, and that's really dependent on how much these drugs are going to cost. So that's where most of the costs are, right?
Yeah,
if that's what I'm understanding correctly, that the incentives are based on how much, how cost effective you are. Is that correct? Can you please kind of?
Yeah. So definitely the primary evaluation in this is cost. There is a quality piece that is a small percentage of it, and that how you perform in that also increases your shared savings and also actually determines continued eligibility. But the primary evaluator, as far as getting a check or not, is tied to cost. And again, it's linked to your own experience. So knowing that obviously, they're going to have probably a mix of different patients in different stages of their disease. Again, that compilation of different patients in 2019 may be the same or sort of similar in 2004, and how potentially that they are managed could have opportunity as far as cost savings.
And let me just, drugs are excluded, correct, Jessica?
Yeah, Part D is not included.
Yeah, so that's really important for you guys to understand that the D is excluded. So if you get hit with a situation where a new D drug you have to use pops out, it's not going to blow you up. Some things that we could consider doing to try to be successful would be really focusing on patients who are complicated and maybe you're ending up in the emergency room or doing things like that because they don't have access, and that might be an intervention. And obviously we get a group of docs together and figure out interventions where we can reduce costs. Dr. McMurray?
I just wanted to point out that rheumatology has a lot of drugs that we use medical benefit for, because we buy and bill a lot of, and do, especially for Medicare patients, because it's often cheaper for them, for us to do it in the office. So I don't know how that can be accounted for.
Well, is that a D bill or a B bill?
That's a B. Medicare Part B is employee.
Yeah, well, that's gonna be built in then. So we'll have to think about that depending on which episodes we pick.
Well, most of our disease states require, and most Medicare patients are going to be on the medical benefits. They're hardly going to get any drugs. So yeah.
But the good news is that you're doing that now. This isn't like a new behavior, right? So the cost related to that is baked in. So that's going to be counted in your target price. Unless, now again, the problem then becomes when we have a new drug come out that throws things off. But if you have a new Part B drug that's less expensive, then maybe that could throw things in another way. So that is going to be a challenge that we'll have to deal with if we're going to try to be successful in the shared savings. I would argue the real reason to do this is to avoid MIPS, which, if you notice, next year you can get as much as a -9% on MIPS if you don't report. So this means that you're at least not dealing with that. As long as Congress acts appropriately, you'll get an APM bonus, which is nice, right? So that's the other big reason to do it. And then the third reason is to familiarize yourself with this with no risk, with all the stuff that's coming out. We're going to have an RFP coming out from CMS/CMMI with mandatory payment models in the next few weeks, right? So it really makes sense if we can get you into voluntary ones with no risk and possible upside. That's a lot better situation than the rest of the country is going to be dealing with. And I don't think you guys are on the chopping block in the first line, but it's only a matter of time. So in my mind, those are the real reasons that it's worth messing with this. And that if we can figure out a game plan with smart clinicians like you guys on how to hit the shared savings, and that's like icing on the cake. That's a bonus. And that's how I see it.
I have a quick question. Like if you don't buy and bill and you go through specialty pharmacy, would that cost of the medication be included or no?
Part D, it's not included. If it's Part B, it will be.
I'm sorry. What was it again?
Sorry, if it's Part D, it would be excluded, not into this cost. But if it's billed out under Part B, it would be included in this cost.
Oh, okay.
So most likely, most of the pharmacy related, especially pharmacies, all going to be in D and not included.
Okay.
But again, I would not suggest doing things that are bad for your patients in any way, right? So, I mean, I think if you have a way that you're dealing with it, you've been dealing with it that works and is resulting in good quality care, I don't think you upend it for this, right? I think you want to make good choices and not, that's the better way to do it is to figure out, you know, what do we have that are real outliers that are really, do we have a patient we've had difficulty managing? Do we want to focus on those one or two patients that we think are in these episodes that have rolled into an emergency room? You know, that is something that would make a lot of sense. And I don't know how many of those you have. I suspect you're a lot smarter than me than thinking about how could we save costs that don't affect physicians? You know, how can we save costs that affect other entities, right? That would be what we would want to focus on.
Does this focus only on our visits, or suppose they go for back pain to the orthopedic surgeon or a neurosurgeon? Does that visit even encounter add to the cost?
It would.
Or this is only for our visits, our office visits?
No, it would. So I again, one of the sort of pillars is looking at, you know, coordination, collaboration across the continuum. So obviously there's a single physician that's attributed the episode or the beneficiary, but that of course does not mean that they're the sole provider of care. And so other relevant costs and likely other outpatient visits and whether that be to an orthopedic surgeon or primary care, you know, things like that would be included in this. But just as a reminder, it's also included in your methodology and your baseline. So it's not like a brand new cost that's added on or anything like that. Again, you're trying to sort of beat how you performed or the patterns sort of, or potentially utilization opportunities in 2019 compared to 2024. But it does include not only your own particular costs, it would be across the continuum.
Physical therapy, everything, basically.
Yep.
X-rays.
Yes. And I think that's also where, again, we want there to be enough there that there's opportunity. If it's so defined, if the episode's so narrowly defined, there really isn't any opportunity when it comes to cost savings. So it does cast a pretty wide, net. And again, the link in the playbook shows all of those relevant costs, a couple pages of them, which I didn't include here, of what's included within that time frame.
Sorry, may I just ask one more question? I don't want to derail your whole presentation, but so if my rheumatoid arthritis patient whose primary diagnosis is rheumatoid arthritis and who's at a higher risk for cardiovascular disease because of their rheumatoid arthritis ends up in the ER with a cardiac issue and ends up having open heart surgery, those costs are attributed to me.
They're attributed to the episode, yeah. So again, there's a single practitioner that sort of owns the episode. I believe that instance, likely all of those would be in. There's certain codes like trauma type of codes or that kind of fall into that excluded cost bucket over here, or cost not assigned. So it's not necessarily the total cost during that whole thing, but most of those costs likely would be assigned to that episode.
So would the people in the hospital have to also use like the code for rheumatoid arthritis in order to include into that episode, or that it wouldn't have to include, so it's all the care that the patient receives then?
Yes.
Going
like
forward.
It's essentially all care. There are some costs specifically like, trauma. I think some cancers and stuff like that are excluded in those events because it would be a true outlier when it comes to cost. But once the patient is in the episode, once we're looking at them and tracking them, all of the costs, independent of who performs them or what the primary diagnosis code is on them, are included in it. And again, same methodology for 19 as well as 2024. So you probably will have some of these patients that have we have really a lot of costs associated with it. And hopefully you have some on the other end too to kind of create that target price average. But again, there's possibly opportunity there as well when you look at potentially reduction of readmissions and other settings of care that may be lower cost for some of this. And feel free to continue asking questions. I feel like it's good dialogue. So just a reminder of where we kind of were. So we went through that step as far as like you saw savings, you fall into one of these 3 tiers. And here's where we talk a little bit about that quality question that was asked. So 5% of your shared savings. So let's say you fall in that top tercile and you initially would receive 80% of the shared savings. 5% of that is held back. So you get 75% and you earn back the remainder 5% based off of the quality scores. And we'll have a slide of what I'm talking about when I'm quality scores. So that's sort of the next step. Finally, we do check an incentive payment cap. So mandated by CMS, an incentive payment can't exceed 25% of the prior year's Part B payments. We don't anticipate getting anywhere near that. That'd be quite a large amount. But again, there is a ceiling associated with the check. And then finally, we send the check to you guys. So again, just as a reminder, it's a single check that's sent to the entity. So again, that aggregate performance of all of the physicians in that group. And it's sent about 9 months after the close of the year. So for next year, calendar year 2025, you'd be looking in that late September, early October range for actually receiving your shared savings for the prior year. I mentioned early on, this is upside only, but we do have some guardrails when it comes to continued participation. The biggest one here is DIS savings accountability. So again, the purpose of having this is we want to ensure that the program is, driving meaningful improvements and focused on quality improvements and cost reduction. So essentially what this savings accountability plan says is that if an entity creates DIS savings in one performance year, they're required to offset that savings in the following performance year before they get their check. So if you think about that flow chart that we just went over, we'd add one more sort of bubble or step in there that would determine if any DIS savings from the prior year needs to be offset. Additionally, if an EQIP entity is in the lower 2 terciles, so that 0 to 66th percentile, and have 2 consecutive years of DIS savings, they're no longer eligible to continue their participation in the program here. And again, the logic here is that since EQIP is upside only, and we are offering, that AAPM status and the bonuses and bumps that come with that, we want to ensure that the physicians and those that who participate are not only doing it just for the APM bonus, but also, focused on driving the cost down and improving quality associated with that episode. Additionally, we do exclude the top performers or that top tercile because, as we know, if an entity is already inefficient, it might be hard to continue to see savings year after year, or you kind of get that race to the bottom mentality. So the quality metrics, so we talked about that 5% is sort of held back or earned. You earn that remainder 5% based off your performance. Just as a note, these 3 quality metrics that were selected, we wanted to make sure that they were available through Part B claims. So we did not want to add an additional reporting burden onto you. Again, it's something that we can fully get from the data that's already available. And these are the same 3 quality measures that are measured across the board, independent of a physician's own specialty or the episodes that they select. So those three of them are, and I'm going to move to the next slide because it goes into detail, advanced care plan, the documentation of current medications in the medical record, and the BMI screening and follow-up. So how do we actually measure that? So the way that we look at this is that for each episode triggered, we look at the end of the performance period. So for the two that we just talked about, it'd be December 31st of 2024. And we look at the full year back, so all of calendar year 2024, and we determine if these measures are performed by any clinician. So they do not need to be performed by you, the attributed provider. They don't even need to be performed by a physician that's currently enrolled in EQIP. They can be performed by any clinician at any time during that calendar year, as long as it appears on a claim, so that we can account for that metric being completed. This goes back to, again, that continuum of care. It may make sense to, work with your referral source, whether that be primary care or someone else. And they might be the practitioner that aligns better to actually perform these quality metrics. But again, the measurement and accountability is at the episode level. So we'll determine if it's being completed for that patient. And finally, we go to timeline. So like I said, the biggest takeaway date here is Friday, September 1st, which is actually next Friday. And that is the date that enrollment closes. The next opportunity to participate would be for calendar year 2025. And we would sort of have the same time period. So July and August of next year would be the time to do that. What happens from September through the start of the year, that really is our focus on the vetting and contracting phase. So we go through and ensure that every NPI that is selected into our system or electing to participate does get vetted by CMS, is eligible to participate. And then we work to ensure, are there any volume or other thresholds that maybe need to be tweaked if they're not met. Again, we'll work with you to ensure that that is accurate and correct. And then we move to a contracting phase where, again, every physician needs to sign a contract to basically officially seal the deal and say they agree to participate in the entity and have their performance evaluated as a group. And finally, the performance year starts on January 1st. Typically in January, I'd say mid-January, all of that baseline data in 2019 becomes available to the participants. So you can see what your target price is. You could look, we have CAN dashboards that enable you to compare different physicians and what their costs may be compared to their aggregate, again, to see if there's opportunity. Looking at your sequence of care, are there potentially opportunity to look at like a certain amount of readmissions or other types of resources that have opportunity for reduction? All of that becomes available to you. And we update it, your performance is updated on a quarterly basis. So we'll give you that information. The great news that it's claims related is you don't have to do any reporting or anything like that. The negative when it comes to that is there is to be expected a data lag, since we are dependent on complete claims to be able to determine your actual performance. So that's just as a note as why we see these quarterly updates. And I think that's it. Hopefully I covered most of it. I'm happy to answer some more questions that have come in and talk about.
I just wanted to add one other thing. So obviously, and I know looking on this call, we have a lot of practitioners who practice by themselves who are smaller. So in order that you can qualify, and I think Jessica went through how you qualify with the episodes and the bundles pretty well. But if you wanted to qualify for more bundles, or you want to be able to even participate in the program, if you don't have enough by yourself, what we are doing at MedChi is we are creating a MedChi EQIP entity, and Dr. Mari will be the lead care partner. And our game plan is that anybody who wants to be in it can be in it at no cost. And that way we can try to manage them as a group. And if for some reason you don't have enough episodes to qualify, you can get in and get your AEPM status. So I know we're going to put Dr. Mari's group in, and I think we have another group that's expressed an interest as well. But if there's anyone else who wants to do that, or you want to talk about that, we can talk about that. The other thing that we can do is if anybody wants to send me or Jessica your NPI, we can run and see, or the NPI of your practice, we can run and see what bundles you might be eligible for. And if anybody wants to do a one-on-one discussion, we can try to do that too. I will point out we have literally 2 weeks to get everybody signed up and in this if they want to do it. We have until September 1. So we need to get moving if anyone's interested. We can take any questions, having said that. Don't be shy. No, any concerns or questions or?
And Jean will circulate these slides for you guys to review. I know the codes, I'm sure, are very important for you guys to look at, so you'll be able to.
And we'll put the slides and the video on the website. Will, did you want to add anything?
Is
Thanks,
there, I was just wondering, is there like an email or is there a specific person that people can email if they do have questions after? Okay, so wanted to make sure that that was pointed out again.
Yep.
Probably the best person to email is Jessica or myself. And my
Okay.
email's not up there, but I'm gransom@medchi.org, and one of us can help you sign up if you want to do that, or help answer questions about signing up. Go ahead, Will. Do you want to say anything or add anything?
If there are other practitioners or providers that you think might be interested in the rheumatology world who weren't here today, feel free to, let them know about it, and they can get in touch with us as well.
Okay.
Well, thank you. We do appreciate your time.
All right. Well, thanks everybody for participating. And again, don't hesitate to reach out to any of us. We're happy to help you. And hopefully we can get some people signed up.
Thank you.
Thank you.
Thank you.